I went to high school in Salt Lake City, Utah. As we know, Salt Lake City in Utah is not very diverse. And so in my high school group of friends, you were not white, you were not Mormon. It was just a collection of us. And so one day I remember one of my friends, and this is the mid 90s, was saying, you know what, we're all going to die of HIV one day. It was like shocking and actually, in a way, true at the time, probably. So that's really how that sparked my thought about HIV. I actually didn't even think about medicine for many years later, but that's kind of how I thought about it, is looking at my group of friends who are mostly brown and black, also gay. That was what our future looked like.
Please note that the opinions and ideas shared on this podcast are those of the speakers, not the opinions of the Ogden Surgical Medical Society or its board. While medical topics will be discussed, it is not to be taken as strict medical advice, and individual clinical judgment is warranted in applying information to patient care. It is the responsibility of the listener to judge for themselves the applicability of the information discussed with regards to their medical practice.
Welcome to the Ogden Surgical Medical Society podcast. Today's topic is on update on HIV in Utah and Utah's first and only free HIV prevention clinic. My name is Dr. Petronella Adomako. I am an infectious disease doctor at McKay Hospital. We have two guests for today. Our first guest is Dr. Susana Keeshin. She received her medical degree from Meharry Medical College, completed her internal medicine and pediatric residency at the University of Utah, and her infectious disease fellowship at the University of Cincinnati. She is currently an assistant professor in the Division of Pediatric Infectious Diseases at the University of Utah and Primary Children's Hospital. She cares for adult HIV patients in Clinic 1A at the University of Utah and pediatric patients at Primary Children's Hospital. Her clinical interests include medical care of people living or affected by HIV, transitioning HIV-infected youth into adult healthcare, treatment of HIV and hepatitis C co-infection, HIV pre-exposure prophylaxis, which is known as PrEP, and that's the one we'll be talking about today, and general infectious diseases. She is a co-founder and leader of Utah's first and only free HIV prevention clinic. Welcome, Dr. Keeshin. And our second guest is Dr. Adam Spivak. He joined the faculty of the University of Utah Department of Internal Medicine, Division of Infectious Diseases in the fall of 2011 after completing his residency and fellowship training at Johns Hopkins Hospital in Baltimore, Maryland. He cares for people living with HIV infection as a member of the Infectious Disease Clinic and attends an inpatient infectious disease consult service at the University of Utah Hospital. He teaches in the medical school, mentors postgraduate trainees, conducts translational research on HIV persistence and eradication, and is also a co-founder and leader of Utah's first and only free HIV prevention clinic. He is also a scientific member of the NIH AIDS Clinical Trial Group and an investigator in the NIH Recover Cohort study, studying post-acute symptoms of COVID-19 infection. So I'd like to welcome both of you to today's podcast, and thank you so much for agreeing to be a part of it. Welcome again.
Thanks for having us.
Excellent. So I will start off with Dr. Spivak, because you have been here a little bit longer. Can you tell us about HIV in Utah?
Sure. We might as well start at the beginning, which is before either of us were here practicing. So of course, HIV and AIDS was first described on June 5th, 1981 by the Centers for Disease Control. And the first case in Utah, I believe, was identified a few years after that. It was in the mid-1980s by Dr. Kristen Rees, who eventually became the provider of most, if not all, people living with HIV and AIDS throughout the 1980s and early 1990s, at which point she moved her clinic from what was Holy Cross Hospital up to the University of Utah. So this was, of course, a global epidemic and affected every place. But in Utah, there really was more or less a single group of providers doing most of the work with regard to this infection. And of course, once the clinic came to the University of Utah, which is a big academic training hospital, lots more folks got involved. And of course, there's a lot more history in there that I'm not qualified to go into in terms of all the other providers. But fast forwarding to the 2010s, I arrived with my wife, Emily Spivak, who's an infectious disease doc as well, in 2011 here, and joined a really fantastic team of people caring for people living with HIV here at University of Utah. As Dr. Keeshin mentioned, we were both interested in HIV prevention. And actually, I'll stop myself there because I don't want to overrun. Stop there in terms of the origins of HIV care here.
Okay, well, thank you. So I am presuming, right, that the numbers of HIV in the state of Utah when it was first diagnosed is not as many as we have currently. Do you have an idea of the number of patients with HIV in the state of Utah, Dr. Keeshin?
That's an interesting question. It's somewhat a confusing number to come up with, but I know the Utah Department of Health says anywhere from 2,500 to 3,000 people currently live with HIV in our state. The exact number we don't know, but that's kind of the round estimate, what we see today, kind of mid-90s high school time.
Okay, thank you. And Dr. Spivak, I see that you do partake in a number of clinical trials.
Mm-hmm.
So again, what got you interested in that? And can you tell us about some of your trials?
Sure. Yeah. So I grew up in Baltimore, Maryland, and I went to medical school at University of Maryland downtown and residency training in Baltimore at Johns Hopkins. And Baltimore has always had, it's been particularly hard hit by the HIV epidemic. And so throughout my medical training, it was a really omnipresent disease. It was very, very common to be admitting patients and caring for people living with untreated HIV infection. And it's a devastating illness. And it really was brought home to me, speaking about my upbringing as a child of privilege. Really, this was a disease in the 1980s. I can remember learning about and asking my parents about something I didn't understand, but that I knew I was afraid of. And I was, sort of taught in the way that parents like to console their children that it's okay. This is not going to happen to you. It's going to happen to someone else. And that's not a very satisfying answer, this concept of other, us and them. One of the things I think that is a critical teaching of infectious diseases in general is there really is no them. There's just us. And these false dichotomies are so devastating, and yet we're all so easily divided, it seems. But in any case, working and training in downtown Baltimore, very close geographically to where I grew up in these leafy suburban areas north of downtown, was really a very different world. And it became clear to me that I had aspirations initially to go overseas, sort of romantic visions of saving the world, et cetera. I didn't really have to go very far from home to serve a community that I could try to provide some help to. And HIV was and continues to be a disease that really disproportionately affects and kills lots of otherwise young, healthy people worldwide. And so it became a very, again, because it was so prevalent and something that seemed a lot more effort was needed. And it's just also a very fascinating disease. It was something I decided to get more interested in, more involved in. So I do some clinical trial work with the AIDS Clinical Trials Group, and that's really focused more on the research side of things, which is a little bit astray from what we're talking about today, but just in a brief summary, of course, as you all know, you put people on antiretroviral therapy and they do very well. but they're not cured. And that's important from a clinical standpoint because there really aren't enough drugs to go around. We're asking people to take a daily pill every day for the rest of their lives that may have some side effects. And of course, there's stigma still of living with HIV, even if you're on treatment. And so the need to find a way to cure the disease, to eradicate it fully is really there, I think, and may not be quite as high a clinical priority as other ongoing pandemics, but it's out there. And so I'm involved on the lab side, ways to study that phenomenon of the HIV persisting in the body, what we call the latent reservoir, and some ways to potentially flush out that virus out of its hiding places in the immune system. So I'll stop myself from going on and on about the lab side of this, but that's really the focus of those ACTG NIH trials is really focused on HIV eradication.
I'm curious about those latent reservoirs, but I'll come back to you on that. Dr. Keeshin, I think yours is interesting. You see HIV patients who are children, and then you see them transitioning to adults. What is your experience with the HIV in children compared to the HIV in adults?
Very different. So drugs that we use in adults, I don't see them come around to the pediatric population for 5 to 10 years. Same with pregnant women, actually. So I think the average kind of lag time for us to have PK studies in pregnant women is 6 years. So for example, we still don't have PK data on Biktarvy, which is a common medicine we all use every single day, but actually we don't know the PK data in pregnant women. So it's very similar to children. We lag in time because you know, the adult studies get done, it looks good, okay, it's efficacious, and now let's look at it in kids. And so there's always this lag time. It has gotten slightly better in the last 5 years in that they're studying pediatric trials at the same time now as adults. But that part is different, is just using a lot older medicines. The other thing is throughout childhood, the majority of my patients will have lost 2 classes of medication. So they're highly treatment experienced. They've lost at least a class or 2 of medications. And so their regimens look very kind of a little bit crazy. And that's just because of resistance. And there's key times, you know, whether, you know, I care for a child that hasn't received HIV medicines until the age of 5, whether a lot of my patients are refugees. So some of them were diagnosed in a refugee camp. They didn't have genotypes. They were placed probably on the wrong medicine. They developed mutations. And then the other key time for some of these is adolescence. And so we kind of developed this like me against them, not me personally, but like parents against the child. And sometimes, especially if the child was not aware of their HIV diagnosis, they don't believe it, or they have a hard time accepting it. And so it's harder for them to take medication. So that's another key time where I see a lot of resistance come up. So it is different, but I really like taking care of children. That's why I'm a pediatrician, but it is a little bit, it's harder, I guess, but it's really rewarding.
So I'm just curious, how do you motivate them? Because I can imagine that for a child, it would be difficult to take a medication every single day. And from what you're saying, it seems like they'll have to take more than 1 pill and probably more than once a day. So how do you motivate them?
Yeah, so we actually, when I came here, we've always had great case managers, but the communication between the adult clinic and pediatric clinic was fragmented. So when I came here, I tried to unify us a little bit and brought over the case managers in the adult clinic. So we have specific case managers that see our pediatric patients as well as some adults. And that also is to help ease that transition. So they're key at helping us making sure the child takes their medication. We sometimes have, you know, little bets or like, hey, I'll get you a prize, I'll bring you pizza, like all sorts of things if you can be undetectable. The key thing too, when I came here, there were quite a number of children that didn't know they had HIV. And we know in pediatric HIV, it's important to tell the child that they have something going on, even though they may not understand it at an early age. And then as we develop into, you know, an adult, stepwise, we can introduce the concepts of HIV and HIV prevention during that time.
Okay. Do you see a change in their acceptance or behavior or adherence? Is that the word I should use? Do you see a change as they grow older, as they transition to adulthood?
Yeah, oftentimes I do see that. Sometimes we've had children that were not great at taking their meds for whatever reason. And, they enter adult care. Sometimes it's really shocking to them because now they're in charge of everything. And I do try to, prepare the kids like, hey, you're going to have to call them for refills. Hey, you're going to have to do all these things that your mom and dad did before. But there usually is a change, and it's somewhere in the mid-20s, I think. They realize, hey, I could get really sick, because the problem or the difference with HIV in children and in adults, a child's immune system is really robust, just like we know in everything else. And so a child that doesn't take their HIV meds at the age of 14, they still may have an okay CD4 count. And all their life, they'll be like, hey, my CD4 is okay. I don't have to take medicine. But somewhere around the ages of starting about 18 to mid-20s, your immune system kind of breaks and you can become sick. So sometimes they realize it because they're becoming sick, or their CD4 is now crashing, or they're just maturity. That's the other big thing.
Okay, thank you. So Dr. Spivak, what are you going to do with your latent reservoir to help us, to help cure this disease?
Yeah, that's a great question. I wish I had the answers to that. The idea that you could even get rid of those reservoirs was very much considered sort of science fiction, and was not an area of a lot of intense study until about the mid-2000s. And there were these sort of whispered reports, and then all of a sudden there was a New England Journal case report about a person known at that time as the Berlin patient. So a guy named Timothy Brown, who was living with HIV and acquired leukemia, developed AML, and got chemo, and the leukemia came back, and he needed a bone marrow transplant, and he got a transplant with stem cells from a donor that was basically lacking one of the entry proteins for the virus. And so the person that donated Timothy's new immune system was immune to HIV. And so the question became, with this N of 1 experiment, if you eradicate someone's immune system and then replace it with an immune system that cannot get infected, what happens? And sure enough, he was cured. And he actually lived another 11 years without antiretroviral therapy. He moved from Berlin back to the United States, where he was originally from, moved actually to San Francisco, and almost became essentially a professional patient. He was poked and prodded every which way looking for virus, and none was ever found conclusively. So he was determined to be cured. Unfortunately, his leukemia relapsed, and he passed away a few years ago. But it's the first known case of someone actually being cured, of one of these reservoirs being eradicated in someone. And an N of 1 is bigger than 0. And so the NIH got interested, and the research really picked up on this idea. We weren't obviously going to scale up bone marrow transplant, which has a 10% upfront mortality compared to a daily lifetime pill, but there was proof of concept that this could be done. What always worried me about that case is that a lot of things happen once in the world that we can't explain. And in science, you certainly want to see it twice or more. You want to see reproducibility. And it took a while. But in 2018, there was a second patient known as the London patient with almost exactly the same treatment regimen. And now there's been a handful more. So there is at least this idea, and at least under extreme measures, that this virus reservoir can be eradicated from the body. The question is whether we can do it in a way that's scalable and safe and that makes sense. And the areas I'm looking at are repurposing some drugs that target T cells, and in specific T cell proliferation, the turnover of T cells, which really drives that reservoir for allowing it to persist for the lifetime of a patient. And also we're looking at natural products. We're looking actually at traditional medicines and some treatments that are not used in Western medicine, but that seem to hold a lot of promise. So those are in much earlier stages, sort of on the lab side, but we're moving forward with some of the FDA-approved repurposed drugs to see if we can target this reservoir in other ways. So I'd say it's early days. We're hoping for reaching for a sports analogy. We're not expecting a home run. We're not expecting to repeat those cases, but at least a base hit. Maybe we can perturb this reservoir. And then maybe ART wouldn't have to be a lifetime treatment for folks.
I keep getting asked that question every time by some of my patients. When are we going to get a cure for HIV? So we'll be on the lookout for that.
I'll let you know.
Sounds good.
Not yet. But.
So we know we have relatively good medications right now. I mean, based on the history, they had to take a lot of pills in the beginning, but now we're down to one pill. And now we know about HIV pre-exposure prophylaxis. So Dr. Keeshin, how did that come about?
So I can tell you how it came about scientifically, but I can also tell you how my mentors describe it to me. My mentors describe it to me in the 2000s. People started to share medications and they started to take half of someone's regimen and they noticed that it worked. So that sparked an idea. And so we had the first trial, one of the first trials, the PrEP study, looking to see if we give HIV medications, not the full set, but a couple of HIV medications, would that prevent HIV? And they found that yes, it was efficacious. And then there were other studies in different populations, people that inject drugs in Thailand. There are other studies that prove the same thing, that yes, taking HIV medications can prevent HIV. So in 2012, the FDA approved the first drug, emtricitabine and tenofovir, for the use of prevention. And then later we had its trade name was at the time Truvada, and then we had another drug called Descovy, which is nearly the same drug, just a different version or a newer version of the tenofovir, and that was approved in 2018-19. And now we have injectable form, which is an IM shot that someone can get every 2 months to prevent HIV. So we're getting new modalities and different ways to use medicine to prevent HIV. And we have found that actually it's the one good thing I feel like from the studies is real life PrEP is actually much better than the initial studies. The efficacy is much higher in real life versus our initial studies, which is always great news to hear, because usually those clinical studies, we kind of select and cherry pick the best patients, but in real life, it works really well.
Awesome. So when it comes to, we know the HIV medications are very expensive. You both work at Clinic 1A. So how do the patients have any help? If those who don't have insurance? Occasionally, I must admit, I've seen patients who have no insurance, who immigrated into the country. How does one go about helping them getting those medications?
That's a great question. And that's kind of why we started our clinic, is we were seeing that, people that need HIV prevention aren't able to get this medication. So we started to looking in how we could do it. We looked at the price of labs, negotiate. Adam is really great at working with ARAP to negotiate lab pricing, although that's kind of, that's a different story. And then we figured out that Gilead, who was making Truvada at the time, would allow us to have the medication for free if you don't have insurance. So we started working with them, and then it all came together with our clinic back in 2018 and starting to give medication to people that don't have an insurance. And I think I do have the statistics. We have over 600 people. We've seen over 600 people in Utah for PrEP. Nearly all the patients stay with us. We've been able to transition a lot of people that get insurance to either ourselves or a different provider. And sometimes I've had several incidents, I know Adam has as well, where someone didn't have insurance, they then get insurance, but then lose insurance. That happened quite a bit, especially during the pandemic. So that happens as well. So we're able to get the medication for free, and the patients don't pay for their labs or their clinic visits.
That's really awesome. So I really need to hear a little bit more. I mean, Adam, it would be good to hear your take. When I see free HIV prevention, so basically you're saying that these individuals get the medications completely free of charge.
We give away free healthcare.
Free healthcare. Wow.
It's a radical concept in our system. But yeah, one of the things that Susana and I recognized as PrEP became more prevalent was that people were able to get it through this Gilead access program. And of course, many expensive drugs have these programs that I believe are part of the sort of FDA approval process, where they set an expensive price point, but sort of create this back door and say, well, people really need it. We'll sort of have a charity arm here. And I'm not all that familiar with the business side of big pharma, but I know many of the cancer drugs have these, and so do the antiretrovirals. And so I saw some patients that were uninsured and able to get on Truvada for free. And just as a sort of putting hard numbers on it, which has been helpful for me, the Gilead, which is an international pharmaceutical company based out of Foster City, California, manufactures Truvada, and they put these pills into bottles, and there's 30 pills in a bottle. They put their label on it, and they ship it all over the place. And the entire process, from when they purchase raw materials, make the pills, put them in the bottle sterilely, put the cotton swab in, cap it, sticker, mail to our pharmacy, that entire process for one bottle costs $7. It costs $7. And so this is actually from congressional testimony on this, so I believe it to be close to the truth. And in the United States, at least as of several years ago, before Truvada became a generic product, if I was to write a prescription for that bottle to take it off the shelf and put it in a patient's hands, and they didn't have insurance, the price tag was $1,800. And it can be higher. I certainly saw patients come back to clinic and say, they just told me $2,100, $2,300, but $1,800 was generally the price point. And again, Gilead, it cost them $7. And that factors in everything that they're doing, $7. In Australia, which has nationalized healthcare, the cost for that bottle of Truvada is $8. So Gilead made back their $7, and they made $1. They made 12% profit on that exchange. But in the United States, it's $1,800. And when Susana and I started talking about this, hearing these numbers and seeing this happen and the way our system works, and this was in the 2017 timeframe, I was pretty upset and angry about what was happening in our country and politically, and I felt pretty unable to do much to change any of that. The idea of trying to address this at a local level, address really what is a social injustice that, frankly, I felt pretty bad about participating in as a physician in our system. We essentially, instead of being angry and maybe yelling on the internet or doing whatever people do these days, we decided that we're going to lean into this. And, I can make Gilead out to be the enemy, and that's pretty easy from those numbers. But on the other hand, this is the system. If they gave away all their drugs for free, they'd go out of business and we wouldn't have Truvada. And they're participating by the rules that are made. But on the other hand, we found they would give us the drug for free. So rather than get angry, we just asked for a lot of it. And we've been doing this now for 4 years. We are in touch with Gilead. They know exactly what they're doing. They support our clinic. So I'm a little less angry these days. We found a way to get around that. And as Susana said, we managed to make it through the pandemic and still thriving.
Great, good to hear that. Thank you for making the effort. And so, Dr. Keeshin, you had mentioned that you use Truvada, and I think we have Descovy as well as injection. So with your free HIV, the free PrEP, are you sticking only with Truvada, or you have the options to offer Descovy and the injection?
Yeah, so working through Gilead, we now get Descovy. We still give people the option of getting Truvada as well. Since now it's generic, it's only $20 to $30 at the pharmacy. Some people, for them, that's easy to pay, and they're willing to do that. We've talked about starting cabotegravir or Apretude. But part of it is that side of things, the pharmaceutical side, the logistics haven't been really clearly mapped out. But they also are obligated to give it for free, just like Gilead did. So when able, we would like to use it if able. For right now, essentially, we give people those options. Hey, we can get you the Descovy for free. We can use Truvada if you'd like, but we would. There's a pharmacy that will mail it to you. It's $20 a month, or I think it's $33 to the university. Anyway, it's going to cost you, and we just let them choose which one they want to use.
I see.
Based on the side effect profile, some people have preferences.
And Dr. Spivak, I'm amazed at the fact that you were able to get the laboratory costs down. How did that come about?
Somewhat. That's definitely still the largest single cost of our clinic. So one of the things that we did, and that's recommended, continues to be recommended with HIV prevention, is to, of course, HIV is a sexually transmitted disease, is to test for other STDs, in particular gonorrhea, chlamydia, and syphilis. And what Susana and I have found is that HIV prevention is a pretty phenomenal STD identification and treatment public health modality, and vice versa. You know, some people come in to our clinic because they want testing for STDs and treatment, and we test and treat all of those for free as part of our routine visits. But as I said, it's very expensive. Syphilis testing is less than $1. The gonorrhea and chlamydia swabs, we do 3-site testing, are $50 each. And the HIV testing is about $10 a shot. So that's sort of starting to learn all these numbers. But when we're doing 3-site testing and it's $50 a test, so it's $150 each visit, 4 times a year for 600 patients, it really starts to add up. We reached out to ARUP, which is obviously the University of Utah Clinical Lab, and explained what we were doing. And they've agreed to provide us the lab sort of at their cost, which again is still pretty expensive. These are molecular assays, and the kits are expensive, and the tech time, et cetera. They also have donated very generously out of their philanthropic arm to our clinic, and that has offset some of the costs as well. But the bulk of our resources does go to continuing that lab testing.
So we are hoping this is a long-term thing, right? We are not seeing any end in sight, I hope.
For the clinic, no. I mean, eventually, if we could figure this out, I mean, the thing I tell the med students is that we actually don't need any more science or clinical trials, really. We have the resources that we need. Truvada turns out to be a very well-tolerated drug. It's cheap, it's generic. It works incredibly well. As Susana mentioned, it's 99% efficacious in the real world, which is better than the registrational trials, which is unheard of. So we could end this epidemic. It really is not an issue or a gap in the scientific knowledge. It's more about priority in medicine and priority in our society, I think. So until we make those changes, no, we'll be around.
Awesome. So Dr. Keeshin, how do you get the message out?
So we talked about this early on about how we are going to advertise, but since our money is really tied up in labs, we don't have much room or to advertise, so we never did. So a lot of it is just word of mouth. Probably, I don't know, 80% of our patients, our new patients, they come because someone else they know is coming to our clinic. We were able to get a free ad on Grindr, which is a hookup app. So I think we set it up for if someone was in 20 miles of our clinic, an ad would pop up and said something like, hey, do you need HIV prevention? Call this number or get on this website. And that worked, and people showed us on their app what it looked like, or they took screenshots of it. We've had a few patients that are really great. You know, honestly, they're like peer navigators that shuttle a lot of patients in. I have one patient, he's always bringing us new people. So we really have not advertised at all. And I think, you know, we're still pretty well known out in the community, which is really great. So it's really just been word of mouth. We have not done any advertising.
So how do we get patients to you? You have other providers. How do we get them to you or refer them to you all?
So the easiest, or how I tell patients, is just Google us. Just put in Salt Lake City PrEP is free, or I think we're like the #1 hit. You can go to our website. Patients can schedule themselves their own appointments. They can also call, but these days people are just going to the website and scheduling themselves, and that's the easiest way.
I see. What's the retention like and adherence to?
Yeah, so it's actually really high. That's what a lot of people ask too, is like, there is this misconception that people without insurance are not adherent, which is totally a lie and not true. Our patients, I mean, I was just entering someone, it was like their 15th visit. And I realized I have to extend the thing because he's going to keep on coming back. But I mean, literally, we've seen people 15 times. They do retain. There is sometimes people do get upset when they get insurance, because then they have to learn about the insurance system, and there's a lot of hoops, which insurance is accepted by the university, or do I have to go to Intermountain, or that can be very confusing. Or, oh, I can't use AREP now, I have to use LabCorp. So that we do have those issues. We really do try to smooth those out. We have a case manager. We're actually on our second case manager, who helps us kind of reconnect people or connect people to care if they happen to get insurance. Or Medicaid. That's the other thing with Medicaid expansion. A lot more of our patients do qualify for Medicaid, which is great. So that's our other kind of entryway into the medical system, is to get them on Medicaid, because many of them are younger in age, although I think our oldest is in their 60s. Our youngest is 18 or so. But again, majority are in their 20s and 30s.
So how often do you see them in clinic?
Just like the guidelines say, every 3 months we see them. And sometimes it's been a mixture. We do telemedicine, and we had actually already had planned to do telemedicine before the pandemic. We were supposed to launch that March 2020. Before the pandemic, but then of course the pandemic happened and we got thrown into telemedicine. So now we offer telemedicine or in-person visits, whatever someone likes to do. Most of the time, these patients are relatively healthy. So, and they actually know, like, they'll message us like, oh, I have a rash. Okay, well, let's see you in clinic. Let's not do it over telemedicine. So it's worked out really well. I think patients like it, having the choice of either telemedicine or in person.
Okay, great, thank you. So Adam, you mentioned that we know that it's not 99% efficacious. Have you ever seen a patient develop HIV?
We have, and actually the numbers are kind of remarkable. Susana mentioned we have over 600 patients in our clinic, and I believe we've identified around 6 new cases of HIV. So the numbers were like spot on in our population. The majority of those are folks that came into our clinic having heard about PrEP, understanding that their risk was potentially high for acquiring HIV, but it turned out that they had. And so it was picked up at their first visit. One of our earliest cases of someone who came in with HIV was someone who unfortunately stopped taking PrEP, but was still having lots of sex with lots of partners, and came in and was having some symptoms, and I believe had syphilis, but also the HIV test was newly positive. And of course, that's unfortunate, and there was that gap in care. But on the other hand, sort of the glass half full of catching these folks who are newly acquired HIV is we get them right into care. And Susana and I are both providers in our clinic. So, we'll get them into our clinic and on antiretroviral therapy. So they're diagnosed, very early on. They're never going to develop any immune dysfunction or develop AIDS. And of course, once we get them on treatment, they're never going to spread HIV to anyone else. So yeah, that 99%, which is everything in life, nothing's 100%. But really, I think it's probably one of the biggest, the most important things our clinic does is really improve the rates of testing among folks who may be at risk of acquiring HIV infection. And that's something that I have a slide showing. I asked the medical students to tell me where we rank as a state in terms of HIV testing among adults. And of course, they generally are pessimistic about this, but it turns out the punchline is that we're 53rd, because of course that includes some territories. But we're the worst state when it comes to testing for HIV. About 25% of adults in Utah have ever been tested once. So, when we talk about this being a, not an epidemic hotspot for HIV, and there's not a lot of HIV here, and I always tell the med students, if someone tells you that, including me, tell them that they don't know what they're talking about. The numbers are terrible. And really, I tell the med students, the most important thing I'll tell you right now is test your patients, because we're just not doing it enough. And again, as we do that in our clinic and we do it frequently, yeah, we're going to catch some new cases. And absolutely, that's a fantastic thing for the patient and also from a public health perspective.
Thank you. So I hear free HIV PrEP, but as you mentioned, it's also a good test. We also test for STDs. So when you have individuals who test positive for some of these STDs, do you treat them? Are those medications free of charge? Do you send them to the health department? How does that work?
So we do treat all syphilis, and that is penicillin's actually really cheap, so they don't have to pay for that. Nor ceftriaxone for gonorrhea, so we'll cover that as well. The chlamydia is a little different. We all use doxycycline now, whether it's 7 days or 21 days, depending on symptoms. It's still fairly cheap. It's somewhere around $7. They do pay for that. And I think even at Redwood, since they have a sliding scale for their medication, it's something like $2 if they go there. So that is the only one that they will have to pay for. We used to offer it for free when we were using azithromycin, and they could come and get it. But since, again, we're using doxycycline these days, it's a little more difficult to give that out for free.
Okay, thank you. Dr. Keeshin, Dr. Spivak, thank you so much for being willing to be our guest on this show. Is there anything you want to tell us about HIV in Utah? Summarizing it, HIV in Utah, what can we do? What can we do to prevent it? What can we do to about the spread? Anything about HIV?
I would reiterate my point that I think testing people for HIV is really the take-home message. We're doing it as a medical profession in this state. We're dead last. We just have to do a better job of making the diagnosis. And as soon as we do that, we've got fantastic treatment for anyone that wants to be on PrEP. We're trying to make ourselves easy to be found. We are more than willing to see patients who want to get on PrEP. And we have a fantastic physician associate we work with who actually does some detailing work, which is getting out and teaching providers all over the state how to test and treat for sexually transmitted diseases, including HIV. So it's another resource that we have. We didn't get a chance to talk about today, but the number one thing would be to test patients for HIV.
Sounds good. How often how is the clinic open Monday to Friday?
So we're open on Tuesday afternoons / evenings and one Saturday a month.
Dr. Keeshin, anything else you have to add?
No, I think the same way. If anyone comes to your clinic asking for PrEP, give it to them. I know there are some guidelines or things that we think that place people at higher risk. If someone asks for it, just give it to them. And then I think some of the other things is just thinking about your population that you do see, especially if someone has an STI, that's a perfect opportunity to talk about HIV prevention. And so it's just a good opportunity that we need to get more and more physicians to test and to ask those questions.
Great, thank you. I know we should be rounding up, but I have to go back to Adam. What resource were you talking about the education of other providers?
Yeah,
on that
yes. We work with a really fantastic PA named Kelsey Genovese, and her funding is partly through our Department of Health contract for a PrEP clinic and partly through a separate Utah Department of Health program that's called Public Health Detailing. And what Kelsey does is go either via Zoom or currently she can go out in person and work one-on-one or with small provider groups. She gives talks. She can talk through individual cases. And again, it's funded by the Department of Health. So there's no cost to anyone's practice, just your time. And she has fantastic resources to talk people through difficult cases, the basics. I want to start prescribing PrEP, but I'm not sure how to go about it. Susana, what would be the best way if folks wanted to get in touch with Kelsey and get on?
I think going through the Utah AETC,
Okay.
they should be able to go through there. I will also plug another Intermountain thing is Intermountain has an LGBTQ patient health echo going on. It's like started last month, I believe, and there's 11 sessions and it's open to any Intermountain provider. And you can just go on the ECHO website at Intermountain to sign up.
Well, thank you both very much.
Thanks so much. Thanks for having us on.